European School of Oncology, E-session will start at 6:15 p.m. Central European Time. Please hold on. European School of Oncology, E-session will start soon. Please hold on. European School of Oncology, E-session will start at 6:15 p.m. Central European Time. Please hold on. European School of Oncology, e-session will start soon. Please hold on.
Good morning, afternoon and evening. This is the conference operator. The European School of Oncology welcomes you to the e-session 530,001. Today's session is, COVID-19 and oncological treatments, any impact on toxicities? As a reminder, during the live session, all participants can ask questions live at any time by simply pressing on the relevant button at the bottom of the page. Questions will be received by Dr. Berardino De Bari, of the Réseau Hospitalier Neuchâtel Les Chaux-de-Fonds, Switzerland, who will discuss them with Dr. Andrea Riccardo Filippi, of the Policlinico San Matteo IRCCS Foundation, Pavia, Italy, with Dr. Giulia Maria Stella, of the Policlinico San Matteo IRCCS Foundation, Pavia, Italy, and with Dr. Alessandra Graiorni, of the University Hospital Zurich, Zurich, Switzerland. Here is an extract of the policy which is published on our website in full. I will now hand over to Dr. Graiorni. Doctor, your line is now open.
Good afternoon. I'm Dr. Giulia Stella from Pavia. I will thank you, the organizer, for giving me the opportunity to discuss on COVID-19 and the oncological treatments, mainly focused on the toxicities and the impact of the novel coronavirus on lung toxicity. As you can see, I am a pulmonologist. I'm working in Pavia University Hospital. I have some problem with the slides.
Dr. Stella, please do a first click with the mouse and then try to change the slides, please.
Okay. I can't be able to go on.
Try to click again on the slide with the mouse. Okay.
Okay. So this is the outlook of my presentation. That is mainly related to the clinical feature and the histological feature of the infection of the novel coronavirus and in lung and mainly in lung cancer patients. Can you go on?
Try to click again.
Okay.
I'm changing for you, but in case.
I will try.
Okay, now you are
doesn't work.
changing.
Okay. So, as you know, the main interest of my on thinking about lung cancer and novel coronavirus is related to the novel immunotherapy, since toxicity of these immunotherapies can overlap on the pneumonia induced by coronavirus. But in this first presentation, my focus will, so you can go on, okay, will be addressed to the main features of the pathogenesis of this pneumonia and lung toxicity. As all of you know, I think that this paper is mainly known to all of you. Lung cancer patients are at the higher risk of developing severe COVID pneumonia with respect to non-cancer population. So this is according to the guidelines by ESMO Society, the priority to which, according to which we have to manage cancer patients. And as you know, low priority patients are those patients with stable disease that during the pandemic had no need to intervention, while high priority patients are those patients with clinically unstable cancer that need to be managed also during the pandemic. And this is the novel guidelines by the British Thoracic Society that have been developed to manage bronchoscopic procedures in case of COVID-19 infection. So if we have strict guidelines to address patients to bronchoscopy in order to avoid the spreading of the viral infection on one hand, and to continue to go on to diagnose cancer even during the pandemic novel coronavirus. So what we are doing now, till now, to continue to go on to diagnose lung cancer even in case of coronavirus infection. So this is according to our perspective, so the pulmonologist perspective, the definition of lung abnormalities in SARS-CoV-2 infection. So in case of chest X-ray and in case of CT scan diagnosis. And in this case, you can see that ground glass opacity lesions are the most frequent lesion in case of novel coronavirus infection, followed by the so-called crazy paving pattern infection, alterations, and consolidation, and as well as linear opacities. This is a case of a patient that came to our observation at the beginning of March. It was a patient treated with immunotherapy, and this is the evolution after the infection of the novel coronavirus, and the patient, which led the patient to death after a few days due to acute distress syndrome damage. That is the most frequent alteration that we found in this patient, and not only in cancer patient, I have to say, but this acute respiratory distress syndrome was the most frequent cause of death in this in patient affected by novel coronavirus. Sorry. Okay. And this is the partition analysis of the patient that were hospitalized to the our pneumology unit in Pavia Hospital. And what is important to underline, in my opinion, is that the neoplastic comorbidity wasn't so relevant in inducing mortality of this patient. So I'm sorry, since the slides, this is the Italian, but I think that all of you can understand that no impact in the survival of our patient was induced by neoplastic comorbidities. This is a quite interesting and maybe surprising observation, since on one hand, the occurrence of hospitalized patients with cancer was very low, and on the other, those patients that featuring cancer, lung cancer, that were hospitalized did not do not die for cancer and cancer mortality and cancer comorbidity was not so significant. Okay. You know that cancer patients are on one hand more susceptible to viral infection. This is known for influenza virus, and it is emerging also for novel coronavirus infection. And so our expectancy was to have so many lung cancer patients hospitalized for novel coronavirus co-infection, but that wasn't the case of our patient in Pavia Hospital. So, sorry. Okay. And this is why the pathogenesis of COVID-19 and immune checkpoint immunotherapy and cancer therapy was sorry, can you hear me? Okay, so. And so, what about the pathogenesis and cancer patient of the pathogenesis of novel coronavirus and lung cancer in lung cancer patients, and why the incidence of lung cancer patient was so low in our population? So maybe that causality, so the limited population described, and the higher incidence of not diagnosis coronavirus without in absence of laboratory confirmation, but there are also some biological evidence. This is mainly related to talking about immune checkpoint inhibitors, since immune checkpoint inhibitors are able to restore cellular immunocompetence. They can interfere with the so-called cytokine storm that has been associated to COVID-19 pathogenesis and to multi-organ failure. And so also to the previous evidence, as I said before, that cancer patients affected by influenza virus respond, have improved their outcome when treated with immune checkpoint inhibitors. So I have some problem with the slide. Okay, so the previous one, please. Okay. So what the immunological events during COVID-19 pathogenesis? So on one hand, we have an increase pro-inflammatory release of pro-inflammatory cytokines, I mean, such as TNF alpha, MPC1, and so on. And this observation has been demonstrated mainly in those patients who had mainly adverse event, I mean ICU admission, sorry. On the other hand, we have the secretion of Th2 cytokines, related cytokines that suppress inflammation. And on the other hand, we have an increase in IL-6 levels in severe patients. But it is till now unclear if IL-6 levels are detrimental or beneficial to the COVID-19 pneumonia development. Okay. So, in this perspective, I have another clinical case that came to our observation about 20 days ago, and it was a female, 65-old, a previous past smoker, treated with immunotherapy, and who developed a recent worsening and dyspnea. How can we establish if this pattern, I mean this ground glass CT scan pattern, can be related to the cancer, to the treatment, or to the novel COVID-19 virus? So this is what we performed. On one hand, we have the laboratory test that showed us that a normal blood cell count, a quite normal LDH level. The patient wasn't in a respiratory failure. The oxygen pressure was pretty normal. She had the CT scan, as you can see, the ground glass opacity, that was monolateral and homolateral to lung cancer in absence of vascular embolism. On the other hand, we perform the nasal swab that was negative for COVID-19. And then, according to what I previously showed you, the British Thoracic Society, we perform bronchoscopy and test for COVID-19 on the bronchoalveolar fluid. And the bronchoalveolar fluid was negative to all the culture and even for COVID-19. So what is the message of this clinical case? That even in case during the pandemic and in case of IC toxicity, we cannot forget that we are in front of a cancer patient, and in this case, that imaging, that CT imaging was related to a lung cancer recurrence. So I mean that not all that glitter as ground glass opacity is of course COVID-19 related pneumonia or even an IC toxicity, but in that case it was a recurrence of non-small cell lung cancer. That was, in my opinion, also the most probable diagnosis that could we expected for. I think that the next speaker will focus its presentation on this differential diagnosis, so I will skip on this slide. And what is important, in my opinion, to underline is that in the pathogenesis of the pneumonia, of severe pneumonia of COVID-19, there is this is the cascade of events, mainly the activation of the monocyte, macrophages, and dendritic cells that lead to the release of IL-6 cytokine and the trigger of Th17 differentiation, the lymphocytic changes, the activation of endothelial cells that all together give rise to the what we under the clinical profile can see in the patient. I mean, the systemic cytokine production that lead to hypotension, to systemic multi-organ failure, and to vascular thromboembolism. That is, that altogether are the clinical feature of COVID-19 pneumonia, leading patient to death. So in this perspective, there is the rationale to the role of immune blockers such as tocilizumab and other similar drugs. I think that also in this case, the next speaker will be focused some slides. So I can see the okay. So what is important in this point is that we have to take in mind that the cytokine release syndrome in cancer is a quite unusual phenomenon, whether in COVID-19 can be considered as a late event, and so there is the release of highly pro-inflammatory cytokine, the activation of CD8 CT cells, and so the concentration of cytotoxic granules that lead to tissue damage, direct tissue damage, maybe in the lung, which is important, where the COVID infection, but not the only target, of course. The response is dominated, as you can see here, by lymphocytes. Sorry, I have some problem with the slides.
Yes, if you want, we can change for you, Dr. Stella.
Okay, but I don't. Okay, sorry. Can you see the slide presentation or not?
Yes.
Okay, so it's a problem of my laptop or my connection, maybe. Here you can see.
Yes.
Okay, sorry, it was the problem of my connection, maybe. So in this perspective, there is the rationale of the use of tocilizumab, and again, I can skip here since I think that is the topic of the next speaker, maybe. And so just few points to summarize the clinical implication of the use of anti-cancer drugs, I mean immunotherapy during COVID-19 pandemic. So there is an efficacy that has been demonstrated in IC-induced lung toxicity, that IC immune checkpoint inhibitors can be mitigate or increase the severity of COVID-19 pneumonia, that the efficacy of some drugs, maybe tocilizumab, or at least other antiviral drugs such as remdesivir, are still under investigation. So from this perspective, we don't have any specific drug to use in lung cancer patients affected by COVID-19 pneumonia. And my last two slides are related to a study that we
Sorry, Dr. Stella, if I interrupt you, but I think that we are seeing just the slide CRS, synergy between ECI and COVID-19.
So I don't know. You share the slide for me. So
yes.
the last two slides. So this slide number 23. This
one? Okay.
Okay. This is just to show you a study that we are trying to start in Pavia University that is focused on the role on PD-1, PD-L1 inhibition in non-small cell lung cancer affected by COVID-19. That is an ongoing project in Pavia Hospital, just to trying to underline if the immunotherapy could have a role in modulating the evolution of COVID-19 infection in lung cancer patients. And so, okay, this one, okay. We aim to analyze the clinical outcome of our patients that have been treated with immune checkpoint inhibitors, but also comparing them with the patient treated by chemo and radiotherapy, and to define the clinical and biological and imaging features of COVID-19 pneumonia versus pneumonia induced by immune checkpoint inhibition, and so to define possible differential features between these two kinds of pneumonia in order to allow lung cancer patients to continue their treatment during even during these pandemic events. And so I think that I'm going to conclusion. I have also to thank all my colleagues of the Group Interdisciplinare of the Neoplasia del Torace in Pavia Hospital, and this is my last slides. And thank you for the attention, and please, I don't, and please, if you have any questions, sorry, can you hear me?
Yeah, absolutely, yes.
Because
for
I can't see, I can only hear, I can't see now.
Okay, but in any case, for distance, there are no questions. Personally, I have two comments to do, but I think that it would be better to make the two presentation by Professor Filippi and Professor Curioni, and then discuss all together about also these comments that I would like to make. So I think that we can leave them at the end of the presentations. Would you agree?
Okay.
Okay, so we can go on with Professor Curioni Fontecedro for the next presentation on the immunotherapy and chemotherapy toxicity. Please, Alessandra.
Dr. Curioni, please unmute yourself.
Unmute yourself.
We cannot hear you. You just have to unmute yourself in the lower part of the screen from the left.
You can also activate.
You should hear me.
It's okay. It's okay.
Now?
Perfect.
Yeah. So let me thank the organizers for giving me the opportunity to discuss about this very important topic, and I would like to congratulate the previous colleague who has been really living in a very difficult and special era and during the COVID-19 pandemic. I had the oncology, medical oncology group for thoracic oncology, so I will discuss with you about how the COVID pandemic has had an impact, especially for taking decision on treatment or not in patients with lung cancer. In order to do so, I will discuss with you about the possible interactions between cancer treatment and COVID-19, then some what we know to date about COVID-19 infection and cancer patients, and then to the difficult question that we daily faced to treat or not to treat. So in order to do so, about the interaction of cancer treatment and COVID-19, what do we know and where are the questions coming from? First of all, interaction with chemotherapy. We very well know that patients with cancer are much more susceptible to infections, and this is certainly due to an immunosuppressive state. Such immunosuppressive state can be caused by either anti-cancer treatments, like, for example, chemotherapy, but also surgery. So that's why you might also recall that surgeries have been put on hold, not only for cancer patients, but in general in patients with during the COVID pandemic. We have to take into consideration that also tyrosine kinase inhibitor might have an interaction, because we know that some of these TKIs might lead to interstitial lung disease. And then the big topic of immune checkpoint inhibitors for not only lung cancer, but the many tumor types where immune checkpoint inhibitors like anti-PD-1, PD-L1 axis, or anti-CTLA-4 are approved to date. And I'm thinking of melanoma, renal cell cancer, and of course non-small cell lung cancer and small cell lung cancer. So what are the contra of giving immune checkpoint inhibitors, and what are the contra of this possible interaction? This has been previously mentioned, and as an oncologist, I have to take into consideration that immune checkpoint inhibitors can induce pneumonitis, and this can be, of course, as well a misleading diagnosis in these patients, and as well as giving immune checkpoint inhibitors might lead to acute respiratory distress syndrome and a cytokine storm. And we don't know yet if the cytokine storm is going to support or is going to hamper the COVID-19 infection. How is that occurring, and what are we looking at when we have patients with pneumonitis immune checkpoint inhibitors induced? And I would like to share with you the clinical presentation of a patient with what it was considered to be initially a pneumonia in a patient who was receiving anti-PD-1 treatment. And he had just simply cough and dyspnea, and we started antibiotics. And by worsening of symptoms, in about a few days, we started treatment with corticosteroids. The patient had improvement in radiological findings, but while we were tapering down the dose of steroids, this getting worse and worse. Patient was having a worsening of dyspnea, had an increase of CRP, and progression of these infiltrates in the CT scan. Now, if we look at what was happening in this patient, at that point, the inhibition of the immune response through steroids was not enough. The patient was with a saturation of oxygen of 70% despite 15 liters of oxygen with submask and reservoir. He was in the intensive care unit. We treated the patient with high-dose steroids and antibiotics with no improvement of symptoms. And due to this, we started a combinatorial treatment with several drugs to stop the immune response. And eventually the patient recovered as well as the pneumonia. So this is what we see in the clinic as a possible feature of pneumonitis immune therapy induced. Now, what could be the pro of giving anti-PD-1 antibodies in case of an infection? And I would like to share with you that just these two representative pictures and images. So if we think about a chronic infection, we know that during chronic infection, the infected cell can express PD-L1 on the surface, and this interacts with T cells, CD8 T cells, with PD-1. What happens is that these T cells become inhibited, so it's not activated anymore. And we are talking not about cancer here, we're talking about infection. This is a chronic infection, for example, or the beginning of an infection. Now, these T cells can be reactivated by the use of anti-PD-L1 or anti-PD-1 antibodies, and the T cells will be activated also during the course of an infection against the infected cells. So one important step where T cells can become activated by the use of anti-PD-1 during infection. And what about chronic infection? So we know that memory T cells become more and more positive in the PD-1 status over the time. And this is important because this is a physiological mechanism by which these T cells become memory T cells, and become also, however, exhausted. We know that one of the typical features of exhausted T cells is PD-1. And this is what we try to restore in cancer. And this is what also we try to see to be restored during chronic infection. So PD-1 exhausted T cells by the use of anti-PD-1 antibody will become reactivated. So this could also be a meaning by which using anti-PD-1 or anti-PD-L1 antibody would be probably also positive, could have a positive impact during a chronic infection, and maybe also COVID. We don't know yet. So this is, however, one of the classical questions I got, and one of the typical discussion I was having with colleagues. What do you think it could be the impact of using the anti-PD-1 antibody in this era? Would you be scared to do that? Well, in order to answer this question, what I would like to share with you are the data about what we know about patients with cancer during COVID-19. So if we go just a little bit, step back in 2015, with the old Middle East respiratory syndrome, which had an outbreak in 2015, demonstrated a mortality rate of about 84% in cancer patients, which was about the double of all the other non-oncologic patients. Is it the same now with COVID-19? Well, if we look at this, the latest publication from JCO, which is also and pool all the data of patients with cancer known to date, we know that the prevalence of patients with cancer having COVID-19 is about 2%. And this is about 0.3% is compared to the incidence in other patients. So what does this mean? It means that probably the incidence is not that different, but what we know is from a very small population of patients is that the mortality and the vulnerability of these patients is much higher compared to normal patients. But let's go and look at this into details. So what we see in the next slide, please. It has been reported during AACR by Chang et al. That 28 patients were infected by COVID-19 having cancer. They had a median age of 75 years, and the male gender was more represented. So now 50% of these patients had severe events, and the mortality rate was about 30%. Is that important? Yes, but we are looking still at a very small population of patients, only 28 patients. What is, however, of interest is that the last anti-tumor treatment, if this was performed in the last 14 days from the diagnosis of COVID-19, this increased much more the risk to develop severe events. And this was significant. Again, this is a message from a small population of patients. When they looked at the group of patients, 124, who received immune checkpoint inhibitors, only one patient was confirmed to have COVID infection with mild clinical presentation and short hospital course. This is not giving yet an answer, but this is certainly giving us the interest, and still the question remains open for these patients with ICI, with immune checkpoint inhibitors. Let's look at the next population of patients that were described by Barlesi and others during the AACR last year. So Barlesi was reporting about 7,000 patients that were evaluated at Gustave-Roussy. 1,300 have been tested for COVID-19, and 12% of them were positive. Now, between the first 137 patients diagnosed with COVID-19, at the time of diagnosis, 60% had a metastatic disease, 56 patients, so 40%, were at remission and treated with a curative intent. So we have actually a very nice population of patients, let's say like the 60-40%, so metastatic and in remission. What they could see is that if we look now at the discharged patients are the one who died and are the one who are still hospitalized. This is the mortality rate that they could see. So small population of patients from Chang, from Wuhan, 28% from 28 patients. And here we have 137 patients and mortality rate of 14%. So again, this demonstrates that probably we need to have much larger numbers to give us a real answer. And the rate of infection is not higher in patients, in this population of patients, compared to the non-cancer population of patients. And it seems not to be more lethal or aggressive in this population. Now, knowing this, knowing about the COVID-19 and the cancer, and knowing about the possible side effects of treatment, next slide, please. We could try to think about what could be the next suggestions for and recommendations for patients. So these are now the recommendations from ESMO. Discuss the benefit and the risk of the cancer therapy, the current cancer therapy in this context. The treatment setting, so curative setting, palliative setting, first line, second line, third line. So then the disease prognosis, the comorbidities of patients. We know that one of the factors that was one of the impairing the outcome of patients and of patients with higher number of side effects, severe effects of COVID-19 is hypertension, for example. Then we have to listen to patient preferences and the risk of a COVID-19 infections. So are we looking at pandemic area or not? Next slide, please. So this is what we tried to sort out for patients with lung cancer. I have to admit we have been asked so many times also in the community, and we discussed this so much in the community that together with colleagues from UK and Switzerland, we try to give practical suggestions to treat patients, for example, with lung cancer during the pandemic. And then we try to divide these into groups. So the patients who needed to be started when possible, should not be stopped, might be given preferentially, might be withheld, or should not be started for non-small cell lung cancer and for small cell lung cancer. So it is very important to say that, of course, again, we took into consideration the treatment setting, we took into consideration the prognosis of patients, and we took into consideration as well, and we have to discuss always what are the patient's preferences. Now, there is also one underestimated toxicity, and this I would like to say, when we take treatment decision, we need to involve our patients, and often they feel very alone. They have physical distancing, and this can become a social isolation. So this is from the WHO organization. There are some figures and some pictures, and I'm trying to communicate this also to patients that we think about toxicity, we think about interactions with drugs, we can think about all the mechanism behind that, but we also have to take into consideration that when we decide not to give a treatment to patients, they might feel isolated, and this must be taken into consideration. My next slide is kind of the perspective for the future. We need to resolve, we need to adapt to the new systems and to how we take treatment decisions. So it's not anymore an only medical decision based on guidelines that we had available up to date, and we need to return to normality. So by this, I would like to thank you very much for your kind attention, and I stay anytime available for questions.
So, Dr. Debari, would you like to comment on, or we just go forward with the presentation?
Sorry, I was speaking, but I was muted. Sorry.
Yeah.
So thank you, Andrea. So the question is it an appropriate option to use more doses, so higher doses of pembrolizumab, and a space time of and increase the space time of administration to 6 weeks?
Yes, so we do two things. So nivolumab and pembrolizumab, for example, we are giving nivolumab with a fixed dose for 180 every 4 weeks instead of 240 every 2. And we are giving pembrolizumab at 400 milligrams instead of 200 milligrams. So in this case, every 6 weeks instead of 3, and this in order to reduce the number of visits of patients to the hospital. I have, however, to admit there are some patients who do prefer to come once more often to the hospital because of their wishes. They feel more protected to be often in the hospital. And we have, of course, to accept the patient's wishes. So absolutely, yes, it is possible. And it is also approved what you just asked, Bernardino.
Maria Stella, any comment by your side in this sense? Unmute you.
Okay, can you hear me?
Yes.
Okay, so I don't have any direct experience of treating patients with the immune checkpoint inhibitor since I am a pulmonologist. So, but I agree with the rationale exposed by Dr. Corioni. I think that it could be a good option. And of course, we have to take in consideration the wishes of patients. So I think mainly during a period, a pandemic like this. So I think that quite a relevant point also, this quite unclinical point.
Okay, thank you very much.